Thanks everybody for joining. We're going to get started with today's presentation, Understanding Blood Pressure Fluctuations in Parkinson's Disease. We're very excited to have expert on this topic today. And before we get started, there are just a few logistical things I'd like to cover. So next slide, please. So my name is Bill Patjane. I'm the Executive Director of the American Parkinson's Disease Association, Massachusetts chapter. Welcome to today's presentation. The APDA of Massachusetts has been in operation for decades and offers programs and services to the PD community in Massachusetts and surrounding states. We have received a large response for today's presentation. There has been a tremendous amount of progress in understanding and treating Parkinson's disease. PD is highly individualized from person to person, and not all that is discussed today is relevant to everyone. The healthcare team must be familiar with signs, symptoms, treatment strategies, and how PD impacts an individual patient. Treating Parkinson's disease requires a team approach. Today, we are providing information, and it is not intended as medical advice. We're very excited to have an expert on this subject today. Her name is Dr. Anindita Deb. She is a neurologist and movement disorder specialist who completed her neurology residency and movement disorder fellowship at Boston University School of Medicine. She is currently a movement disorder specialist and faculty member at the University of Massachusetts in Worcester, Massachusetts. Her clinical interests are Parkinson's disease, multiple system atrophy, ataxia, dystonia, and tremor. She also has botulism toxin and deep brain stimulation clinics. Her other interests include global health education, and she serves as the director of the Global Neurology Initiative at UMass. So without any further pause, I'd like to introduce Dr. Anindita Deb. Thank you for joining and good luck.
Hello. So I'm Dr. Deb, as Bill mentioned, and thank you, first of all, to the American Parkinson's Disease Association, to Bill Patjane, and to Kathy Thomas for inviting me to give this talk. And today we're going to cover blood pressure fluctuations in Parkinson's disease. So as an overview, as you may or may not know, blood pressure is controlled by our autonomic nervous system, and the autonomic nervous system has multiple parts to it. There's the central autonomic nervous system that's controlled by our brain, and the peripheral system that's controlled by the nerves in our periphery that go into our gut, our hands, our fingers, our feet, our legs. And within the central and peripheral systems, there are, again, a division in the sympathetic and parasympathetic innervation. And so I'll go into that in a little bit more detail just as an overview, but these systems, these nerves basically control all our muscles, including our smooth muscle, our cardiac, our heart muscles, and different glands in our body as well. And as a big picture overview, this system, the autonomic nervous system, regulates our heart rate, our blood pressure, our digestion, urination, and sexual function, among other things. But those are the common functions that the autonomic nervous system controls. So a little bit more about the sympathetic and parasympathetic systems, which you may have heard about in different contexts. So the sympathetic system is our fight or flight system. And so many people have heard about fight or flight, which comes up in an emergency or even during exercise, where your system really needs to rev up and your organs need to kind of keep up with a high level of activity that comes on potentially suddenly. And so our body has the capability to respond to fight or flight. And that's because of our autonomic nervous system, that there's multi-organ innervation, meaning that the nerves control multiple organs. And how this is mediated is through these neurochemicals called epinephrine and norepinephrine. On the other hand, kind of in contrast, the parasympathetic system is our rest and digest system. So when we're resting, when we're sleeping, our body needs to conserve energy. And in order to do that, again, the autonomic system kind of shifts to this rest and digest pattern. And it does that through more local effects, again, on multiple organs. And this is mediated by a different neurochemical called acetylcholine. And so the way to think about this is that our body is constantly balancing the sympathetic and parasympathetic responses based on what we're doing during the day, whether that is that we're resting or we're digesting or we're sleeping, or we're up and we're active, we're getting ready for the day in the morning, we're exercising. So depending on what level of activity we're doing, our body is constantly balancing how much of the sympathetic system is activated and how much the parasympathetic system is activated. And also when one of these systems is activated, the other one might actually be dampened a bit and vice versa. So it's a bit of a complex interaction, but this is just to give you some of the basic foundations. I don't expect you to be able to read this in a lot of detail, but it's just to show that, again, the autonomic nervous system is quite complex. And you can see this diagram of the brain and the spinal cord and the sympathetic system on the left here and the parasympathetic system on the right, showing how these nerves are coming and innervating all the different organ systems in our body. So functions of all of these systems are controlled and balanced, as I mentioned, through the sympathetic and parasympathetic systems. So why does this matter in Parkinson's? Well, this is important because we hear about and we see symptoms of autonomic dysfunction in Parkinson's disease. And like all symptoms in Parkinson's, some patients have more autonomic dysfunction than others, and everyone has a different kind of constellation of autonomic symptoms that's, based on their disease process. And so one of the most common autonomic symptoms that we see is orthostatic hypotension, which is another term for a drop in blood pressure. I would say that probably 60 to 70% of our patients have some degree of orthostatic hypotension, and I'll get into more detail about this. This is also referred to as neurogenic orthostatic hypotension, or NOH. And in Parkinson's specifically, this is neurogenic because we know that it's the nervous system that's causing this, as opposed to other causes of orthostatic hypotension. There's other autonomic symptoms, of course, other than orthostatic hypotension that includes constipation or GI dysfunction, urinary symptoms, sweating or temperature dysregulation, drooling, and sexual dysfunction, all of which are controlled by our autonomic system, as I showed in the diagram before this. But today we're going to focus on orthostatic hypotension and drop in blood pressure. So what is a definition of orthostatic hypotension? What are the symptoms? There's a sustained reduction in systolic blood pressure by 20 millimeters of mercury or diastolic by 10 millimeters of mercury within 3 minutes of standing or head up tilt. So what does this mean? This means that the systolic blood pressure, when you read a blood pressure such as 120/80, the top number is the systolic, the bottom number is the diastolic. So when there's change in position, and generally from laying to sitting to standing, if there is a drop in that top number by 20 points, or in that bottom number by 10 points within 3 minutes of that positional change, that is the criteria for the definition of and the diagnosis of orthostatic hypotension. Sometimes though, you might be close to the 20, maybe you're 18 or 19 and you're feeling symptoms. So, this is not obviously black and white, but, there can be some gray areas, but in general, in order to meet this diagnosis, this is the criteria. And that's also why we don't rely on one blood pressure measurement. We have to kind of get multiple measurements to see if this criteria is being met. Head up tilt testing, sorry, that should say tilt table testing, is not always done to diagnose this, but might be one of the ways in which this gets diagnosed. What are the symptoms of orthostatic hypotension? The symptoms include, at the most severe end, fainting episodes, but more commonly, lightheadedness or dizziness, neck pain potentially, nausea, sweating, blurry vision, potentially confusion, thinking, and memory. And this could be episodic. So when the blood pressure is dropping, you could feel a combination of some of these symptoms. This is not the same as kind of having memory symptoms that are progressing over time gradually, which might be a different issue altogether. This might be kind of a sudden onset of feeling lightheaded and confused and kind of having blurry vision, maybe getting tunnel vision, and feeling like you're going to faint. That is more commonly seen as far as part of orthostatic hypotension. These symptoms could be more exacerbated in the morning. So some patients will have it as soon as they get up and they sit up in bed, and they might feel a little bit, people might say woozy or a little off balance or a little bit lightheaded. And, you know, it could also be confusing because there could be more off symptoms in the morning where the medication, you haven't taken your dopaminergic medications yet and might be feeling off, and they might give you similar symptoms when you're off. But if there's a specific kind of lightheadedness that's coming on or feeling close to faint or dizzy in that way, then I would certainly consider orthostatic hypotension. And also this can occur after meals or particularly in the heat. The reason why it can be after meals is because after you eat, blood is redirected towards the gut in order to help digest the food. And so a lot of the blood flow is going towards the gut away from the brain, and that might make you feel lightheaded or dizzy, especially if it's a big meal that requires kind of, you know, longer period of digestion. And also in the heat, because at that point you might be sweating, you might be losing some volume, and so you might be getting dehydrated, and then that can exacerbate the lower blood pressure and also cause symptoms. So how do we test for or monitor NOH? So your physician might ask you to take your blood pressure at home, and in that case we usually advise taking it laying and then sitting and then standing about 1 to 3 minutes apart for each position change. And so first thing in the morning is a good time to take it when you're laying down, and then sitting up, waiting about 1 to 3 minutes, taking it again, and then standing up and then taking it again and logging down the blood pressure and the heart rate. And if you're noticing a difference, you know, you can make note of it, or you can just jot down the numbers. And we usually ask for a log. So to do this for at least a week or two, just to get enough of a range to see, you know, if this could be an issue. And the reason for that is that blood pressure normally fluctuates for everybody during the day anyway. So there's going to be some natural fluctuations, whether you take this in the morning or the afternoon or the evening. And so if we get a week's worth of numbers, we have more of a sense of what kind of the average might be, or what the range is between the lowest and highest, and also the range, and if it is dropping, how much it's dropping generally, or how often it's dropping. Sometimes we also look for patterns, and if this is happening, is it happening after a medication dose, for example, or is it happening after a meal, like particularly after lunchtime or after dinner time, which could also then guide us as to how we manage the symptoms. So are there other tests that we can do to diagnose orthostatic hypotension? It's kind of nice that we can diagnose this in a fairly straightforward way, either with a log from home, or, you know, if we're able to get multiple numbers between primary care's office visits and visits with the neurologist, we might have some. But at the doctor's office, you may not always be getting your sitting and standing blood pressures checked. If you have orthostatic hypotension, or have had lightheadedness, then I would recommend that when you go into the office to ask to have it checked, at least sitting and standing, but it's not done routinely necessarily. So this is something to just be aware of. So sometimes we may have enough values to say, oh, look, this is a concern, but usually we do need more data. And so that's when we ask you to get some numbers at home. Additionally, we may, depending on what symptoms someone has, we may require more autonomic testing. So what does that mean? If you have multiple autonomic symptoms and we're worried about autonomic dysfunction, sometimes autonomic testing may be recommended, and that depends on what the physician thinks might be going on. And so this often involves a tilt table test, although a tilt table test is not the only part of autonomic testing. But a tilt table test is where you may lie on a table that's gradually tilted up about 10 degrees at a time, up to a 70-degree tilt. And usually the blood pressure and heart rate are measured with each increase. And there's a baseline, and then they measure it as you get tilted up, and also ask about symptoms while the table is being tilted. And so they can note if you're feeling lightheaded or dizzy during the tilt. And again, it gives us similar information as a blood pressure log would. Is there a change in the blood pressure as you're being tilted up? Is there a change in the diastolic or the systolic or the heart rate? And also, are you having symptoms during the tilt? That can be very informative. So the tilt table test, excuse me, is often done by neurology departments, but also cardiology often does tilt table testing as well. There's multiple medications which can affect blood pressure. So levodopa, as you may or may not know, can definitely decrease your baseline blood pressure. And in fact, many patients who are initially hypertensive and have high blood pressure and are on medications, after they develop Parkinson's and are on dopaminergic medications like levodopa, eventually, if we see that blood pressure is low, they may need to lower or even discontinue their blood pressure medications. And this usually occurs after a discussion with the primary care physician and also cardiologist, if cardiology is involved in blood pressure management, to make sure that this is the right decision, and also to determine which medications need to be changed, if at all. So it's definitely not something that patients should be doing without consulting their physicians, but it's something that's interesting to know that, if you're on medications to lower blood pressure, then levodopa and other dopaminergics can lower this, including our dopamine agonists such as ropinirole, pramipexole, retigotone, selegiline. All of these can also worsen NOH. And so if you're on medications, this is something to make note of and discuss with your neurologist. So additionally, medications to lower blood pressure, like antihypertensives, can exacerbate. So if you already have some symptoms of NOH, or you have some intermittent dizziness, but it's not significant, and then you're put on a blood pressure lowering medication, that can certainly exacerbate it. So again, this requires a discussion among your physicians to really sort out what the next step should be. So what are some examples of antihypertensive or blood pressure lowering medications? These include medications such as metoprolol, lisinopril, furosemide or Lasix, amlodipine, and there's many others, but these are some of the more common ones. And sometimes, they might be needed for other reasons that are non-neurological, that are cardiac. And so this is why it's important to discuss with the cardiologist and or the primary care to make sure that it's safe to decrease or lower the dose if needed of these medications. So how do we treat NOH? And so I had mentioned that checking sitting and standing blood pressures at every office visit and at home, if directed, can be very informative. And so this is something, again, that your neurologist may ask you to do. Also hydration. So hydration is very important because often we're dehydrated. and at baseline. And so most people are not drinking enough fluids. And so I usually recommend 60 to 80 ounces a day, which is a lot. So it's, if you have the, excuse me, the 16-ounce Poland Spring bottles or something like that, you're looking at, more than 4 bottles of those a day. And generally the downside of this is urinary frequency, which we know that a lot of patients already are struggling with. And so it's very challenging to keep up that hydration. But what I find is that many people are not drinking much water to begin with. And so even starting to measure or starting to take in some fluids regularly can be helpful. I usually recommend doing this during the daytime, kind of before supper time. I don't recommend drinking the bulk of this in the evening, because then you certainly will be getting up at nighttime to use the bathroom. And so we don't want to make that worse. So I usually say try to do all of your hydrating, in the morning or first thing in the morning, or when you know that you're home, so that when you need to use the bathroom, you're close to it. People ask me about what types of fluids are recommended. It's really water. Water is the best. However, if you prefer kind of flavored water, vitamin water, those are fine. Often we advise adding salt if that is cleared by your primary care and cardiologist. If there's no contraindications to taking salt, then, some people will add electrolytes to their fluids. And so there's different forms of electrolytes, such as Noon or liquid IV, and some of these come as packets that you can add to the water. We often say that light colored fluids are better than dark colored fluids. So what does that mean? So, lighter like juices are generally okay, but they have a lot of sugar. So, it will make you urinate. Same with caffeine. So that's darker fluid. It doesn't really count because, again, caffeine will cause you to kind of to urinate more than it will kind of have you retain fluid. And so, if you do have a cup of coffee, that's okay. But just make sure that on the other end, you're getting enough water in, enough hydration as well. If you're on an antihypertensive, as I mentioned, you may reevaluate the need for this after talking to your physicians who are prescribing it. There's also possibility of changing the timing if you are on an antihypertensive medication to potentially late morning or afternoon. So not like first thing in the morning where your blood pressure might be the lowest, or evening even, depending on, again, symptoms and what your blood pressure log looks like. Compression stockings is something that we highly recommend. And so generally wearing compression stockings will actually raise the blood pressure 5 to 10 points while you're wearing them. And so we usually recommend these while you're up and active. You do not need to wear them when you're lying down or in bed or at nighttime. But if you're up and active during the day, generally it's a good idea to keep the stockings on. The abdominal binder is really for when you might be having more significant symptoms. So feeling really lightheaded that morning, just not feeling well. You might want to have an abdominal binder on hand. And again, what that does is it kind of squeezes that blood flow to go up into the brain, kind of reroutes it from that gut. And so it can be helpful. It's not something comfortable to wear on a regular basis, but it does help if your symptoms are severe. And then we talked about salt, which again, depends on your cardiac history. So something that you don't want to do without speaking to your physicians, but salt can be helpful to raise that blood pressure pretty quickly. I usually recommend things like tomato juice, soups, things that are highly salty, that might be helpful, at least once a day to have something to kind of, especially if there's a time of day where you feel more lightheaded, this can help to just bring up that blood pressure a bit and help you feel better. A salty snack in the evening, kind of after dinner, like pretzels or something, might help to retain that fluid and prevent you from using the bathroom too much overnight. So again, you don't want to have too much, but a little salty snack at night might be helpful as well. So as far as treatment, this again depends on what we think the etiology or what the cause of the NOH is. which we know that Parkinson's itself can cause NOH by affecting the autonomic nervous system, but the medications, like I mentioned, can also contribute. So, this is a discussion with your neurologist about what your levodopa dose looks like and whether you need to reduce that or change the timing, or reduce other dopaminergic medication if that's a possibility. And if not, is there a need for medications to add medications that actually treat the NOH? Before I get to that, just to share some data with you, a couple of studies that were done actually at BU by one of my mentors, Anna Holler, and other colleagues in movement disorders, and Dr. St. Hilaire, of course, is on here as well, where they looked at differences in motor and cognitive function in patients with Parkinson's with and without orthostatic hypotension. So the question is, so I have NOH. Why does that matter? Is that affecting me in any way? If I'm not feeling lightheaded, let's say. And what they found is that patients with Parkinson's who had orthostatic hypotension actually had changes in their motor function and changes in their balance and their cognitive function when they were feeling the orthostatic hypotension symptoms. And so they actually studied this with patients at Braintree Rehab, with Terry Ellis and her group from Sargent College Rehab at BU as well. And so they actually found that having this OH affects functioning in Parkinson's. So as a follow-up, treating these patients for their orthostatic hypotension, again, made a difference in these scores looking at gross motor, balance, cognitive function. And so there's actually kind of objective data to say that treating this is beneficial for Parkinson's patients. And this goes into some of the detail on, what was done for treatment, including reducing the antihypertensive medications, maintaining hydration, potentially decreasing dietary salt, wearing high compression stockings, keeping the head of the bed elevated at 30 degrees. So these are some of the things that can be done to help with the orthostatic hypotension. So what are some of the physical maneuvers that can be used? So you're feeling lightheaded suddenly, and you want to do something quickly to kind of feel better and prevent yourself from fainting. Of course, if you are in a place where you can sit down and lay down, that's the best thing. If not, there's some physical maneuvers that if you're feeling that you're steady or can hold on to something and not off balance, crossing the legs over, and squatting, things like this, or even going down on one knee where you are, these can all be helpful to kind of bring up that blood pressure fairly quickly. I just, caution you that if you don't feel steady or are off balance, then definitely I would not try these without, kind of having someone or something to hold on to stabilize you so that you don't fall. But the best is really to be able to kind of sit immediately and then lay down if you can. So getting into the medication options for treating NOH. And so there's multiple options here. Midodrine is one, and I'll go into each of these in a little bit more detail, that causes vasoconstriction, meaning blood vessel constriction to increase the blood pressure. Fludrocortisone expands the volume in the blood vessels and reduces salt loss so that you retain fluid. Droxidopa or Northera works like norepinephrine. So we talked about norepinephrine in the beginning as one of the neurohormones that kind of can affect blood pressure, can increase blood pressure. And then protostigmine or mestinon, which is then works on acetylcholine, and it's an enzyme inhibitor that sometimes we use as well. So fludrocortisone, the brand name is Florinef. It's a mineralocorticoid. And so what it does, like I mentioned, is it expands intravascular volume, which means that your blood volume increases and reduces salt loss. It's generally dosed, it's a 0.1 milligram tablet, generally dosed in the morning up to twice a day, up to 0.3 milligrams, so up to 3 tablets a day usually. because it kind of helps you to retain fluid, it can cause some volume overload, which means that you might feel some swelling. There could be some leg swelling. And if you have any issues with your heart in terms of volume, this is something that you definitely need to be aware of. I should mention that all of these meds do affect the kidneys. So if there's kidney dysfunction or renal failure, then this should be discussed with your nephrologist as well as to whether these can be used. There's also a risk of lowering different electrolytes. So potassium and magnesium specifically can be low if you're taking this medication. So generally, if you have a history of this, or if we catch this, this should be monitored as we adjust the dosing, because if these are low, they can cause other issues with your heart and other symptoms as well. So it's one of the potential side effects of fludrocortisone. Other things that can happen, so headaches, just because it can increase blood pressure, and then that can cause headaches too, weight gain, and all of these can cause supine hypertension, which means that when you're laying down, the blood pressure can shoot up. And that often happens because that's what happens naturally. And these meds are to help you bring up the blood pressure. So as you lie down, it kind of can push it even higher than what we're going for. So sometimes we may have you monitor the blood pressure in the evening to make sure that it's not going up too high when you're about to lay down. However, this is also why we dose this in the morning. And usually the latest that you would take this is noon, maybe 1 o'clock. And so we don't want you to really take it late in the afternoon or the evening. So midodrine is, the brand name is proamotine. It's a peripheral alpha-1 agonist, which basically means that it works on blood vessels. And this works to constrict the blood vessels so that the pressure goes up, again, because the goal is to bring up the blood pressure in these cases. And the dose, there's a range. There's 2.5 milligram tablets is the lowest dose. And usually, again, this may be dosed in the morning, at noon, and in the afternoon, usually not past 4 p.m. because of that same potential supine hypertension side effect. And so there might be other side effects from this, including that it can affect kind of pupil dilation. If you notice that, it can affect kind of piloerection as your kind of hair standing up. So if you notice that, that can happen. Some paresthesias, which is tingling that you can feel, and pruritus is itchiness. So some people do feel like scalp itchiness or things like this. So these are potential side effects, which, you know, if it's mild and it kind of goes away, we might monitor. If it's more severe, then we may need to stop the medication. Droxidopa is Northera. And so this is actually a norepinephrine prodrug, which means that it turns into norepinephrine. And again, it's used for neurogenic orthostatic hypotension. The dose for this is 100 to 600 milligrams up to 3 times a day, similarly dosed like morning, noon, and afternoon. And in the trial for this medication over 8 weeks, this showed an improvement in standing blood pressure, in symptoms of lightheadedness, and actually most notably a reduction in falls. And so, you know, something to keep in mind is that if you are having multiple falls, then this is orthostatic hypotension is something that should be considered as a cause for the falls as well. Similar side effects as the other medications, the supine hypertension, potentially headaches, dizziness, nausea, and fatigue. And protistigmine is one that we use off-label. It affects acetylcholine. It's an enzyme inhibitor, usually used by neurologists because we use this for other neurologic diseases as well. But in this case, it might be used for autonomic dysfunction, and it might improve the blood pressure quite a bit, and it doesn't really cause supine hypertension. So this is one that can be considered, and it can be used in combination. These meds are all, for the most part, can be used in combination. Northera, usually you cannot use midodrine with Northera, so you might be on Florinef and Northera together, but some people need midodrine and Florinef together, so they might be used in combination. And this can cause other potential side effects. So there can be some diarrhea or more salivation, nausea, vomiting, muscle cramps, and fasciculations, or kind of twitching in the muscles. They're not common side effects, but they are potential side effects of this medication. Sometimes the added kind of GI motility, you see the side effect of diarrhea, but our patients who are very, very constipated or have other GI motility slowing, this can actually be helpful to get things kind of moving. So these are my references for the information that I presented on blood pressure fluctuations, and I would be happy to answer questions that anyone has about this.
Sure. Thank you, Dr. Deb. Fantastic job today. We've got a few questions, and I'll read those as we go along. My doctors suggest that I eat small meals more frequently instead of a heavy meal. Why is that important?
So yes, so as I mentioned that when you eat and you digest, that requires blood flow to be kind of directed to your gut so that it helps to kind of move things through and helps you digest. So what happens is that sometimes you get so much of the blood flow into the gut that you might be feeling lightheaded and dizzy for that reason. So your meals, after meals, you might feel more lightheaded and more of the symptoms of orthostatic hypotension. So if you're having smaller, more frequent meals, then, it doesn't require so much kind of blood flow there. And it might help to kind of mitigate those symptoms rather than having a large meal and really, you might be feeling more lightheaded after that. So that's why the smaller meals, and also it helps to kind of digest the food more regularly, as we know that there can be GI symptoms with Parkinson's, so especially motility and gastric slowing. And so if there is a slowing, if you're having smaller meals, then it helps the gut to kind of process the meals each time.
Thank you. Second question, do you think it's good to check your blood pressure at home from time to time?
So I think this really depends and is really a discussion between you and your neurologist. Not everyone develops symptoms of orthostatic hypotension. So in that case, I don't think it's necessary. And I also, we also often don't want patients to get too focused on the numbers because we really want to focus on the symptoms. And looking at numbers and kind of getting anxious over the numbers can cause more anxiety and more in other symptoms. And so often, unless you're directed by your physician to monitor your blood pressures, generally it's not something that you need to do regularly.
Good, thank you. Do you have any tricks on how to drink more water during the day?
No great tricks. I usually do recommend having a kind of sports water bottle or something that measures how much you drink on hand, and having that really with you wherever you're going, or maybe if you're at home, keeping one in every room that you might be in so that it just kind of reminds you to keep drinking. Often I know for myself, if I don't have water next to me, I won't remember to drink, and all day could go by where I just haven't, seen a glass of water or had, and force myself to drink. So if you're not somebody who naturally is drinking water, you may need to kind of prompt yourself and have water bottles in different rooms, and have some in the car as well. And the reason I recommend the kind of measured bottles is because then you have an idea of how much you're drinking through the day. And that can be helpful for you to know and also your physicians to know.
Thank you. One question is, hear the phrase white coat syndrome as it relates to blood pressure. Can you explain that and what that might mean?
Sure. So white coat syndrome is that when you come into the office to see your physician, generally blood pressure tends to kind of shoot up higher than you normally might be at baseline. And that's because there's some anxiety when you're going in for a doctor's visit. And then you might also be rushing to get there. You might be like parking and then having to run into the clinic. And so because of all those reasons and the anxiety around it, generally when you come in to see the doctor, your blood pressure is a little bit higher than usual. And that's again why we can't necessarily rely solely on the blood pressures we get at the office visit to diagnose something like orthostatic hypotension. It's always helpful to have those measurements from home in your natural environment, in your natural day-to-day, to see like where your baseline is and if you're really dropping.
Thank you. Another question is, how many times a day should the lay, sit, stand blood pressure be taken?
So I think different, physicians have different preferences for what they would want you to do. And again, this might also depend on whether we think that medications could be contributing or meals could be contributing. So depending on all of that, I'd go by what your physician recommends. I generally at least start with twice a day, and the first thing in the morning and once in the afternoon. And then if there's suspicion that, things might be worse after a medication dose, we might add another check in for an hour after you take your meds. Or if you think meals could be contributing, we might check it after a meal. So generally I'd start with twice a day, and then we may need to do a few more depending on when you're having symptoms.
Thank you. How much does coffee raise blood pressure generally?
So coffee does raise blood pressure. I don't know the exact, amount that it raises it, but it's going to be transient regardless. So it's not going to be a, full effect through the day.
Is there any data about hypotension after swimming?
Not that I know of. I can't say that I've looked into that specifically. I haven't really seen blood pressure drop after exercise. I think in general, it might go up a little bit or not really change much, but I wouldn't assume that it would drop after swimming, but I have not looked at that specifically myself.
Another question is, please discuss orthostatic hypotension and with supine hypertension in Parkinson patients.
Right. So orthostatic hypotension, is when the blood pressure drops on changing position. Supine hypertension generally occurs as a side effect of the medications that I discussed, where those medications are causing your vessels, are doing changes physiologically to your body to increase the blood pressure. And we also know that a maneuver like laying down increases blood pressure. So now if you're laying down and you're taking meds to increase it, it might just push it up too high. And that's called supine hypertension. So, if we are worried about this, we might have you check your blood pressure in the evening before you go to bed and see. And generally, again, everyone has kind of maybe a different range of what they're okay with how high it is. And some of that depends on your cardiac history as well. We obviously don't want you to have a high blood pressure through the night. But the cutoff for what is high might depend again on your medical history. So, and we also generally don't want you to be waking up to check your blood pressure through the night. So if we're finding that in the evening, your blood pressure is shooting up to the 180s or 200s or something that's, maybe above 160 for that top number, then we might need to consider changing the timing of medications or decreasing the medications for neurogenic orthostatic hypotension, or decreasing the dose. Or changing timing of your high blood pressure medications if you're on any. So there's different approaches to that. I think that if there's worry about it, you would talk to your physician about checking that blood pressure, at nighttime while lying down.
Thank you. What is the cutoff for safe systolic and diastolic blood pressure in view of falls if no symptoms?
So that is a good question. Everyone kind of lives at a different range of blood pressure. So, something that might be low for me might be normal for you. So, some folks live with their top numbers in the 90s and that's how they've always been. And so for them, that is normal. Whereas others really live around 120s for their normal. So it really kind of depends on what your baseline is. For me, comfort level wise, I generally want to see that top number 90 or above, especially when you're standing. I worry when it's in the 80s, although for some people, again, it's amazing how the body can adapt to low blood pressures. And some people, that's normal for them to be in the 80s when they're walking around. But for me, if you're having symptoms and you're lightheaded or I'm worried about orthostatic hypotension, I generally want to see those standing numbers above 90 for the systolic. And the diastolic, I don't worry about too much. high diastolics are hard to control even with blood pressure medications. And often I defer to my cardiology colleagues to get some input if the diastolic is too high, to get some input there. But generally, we're working more with the systolic, the top numbers.
Next question is, can shortness of breath and tightness in the chest be a symptom of orthostatic hypertension? The person has seen a cardiologist and had a pulmonary function test, which were both normal.
So I would say not the most common symptoms of orthostatic hypotension, especially if there's no lightheadedness or dizziness. Then I would say it's not the most common. You can have those symptoms in off periods. So I would kind of think about whether it's occurring if you're on dopaminergic medications, when the medications are wearing off, are you feeling short of breath or chest tightness? That could be an off symptom, and may be related to the muscles in the chest as well. So not typically, but again, one way to kind of look at this is talk to your physician, see if it would make sense to check the blood pressures and see if you're having symptoms if your blood pressure is dropping and if you're having symptoms that correlate with that.
Good, thank you. Last question. We've gotten quite a few questions that we'll hopefully try and follow up with down the line, but last question is, should you wear long or short compression socks if you have trouble with your blood pressure?
Good question. So again, this really, you have to talk to your physician because it depends on the degree of your orthostatic hypotension. For my patients that might be more mild and, having intermittent symptoms here and there, I might recommend the short ones. I usually recommend the knee highs just because they're easier, more comfortable to wear. However, if you are having severe orthostatic hypotension, then the thigh highs might be more appropriate. So I would talk to your physician about what makes more sense and depending on your symptoms.
Thank you, Dr. Deb. Great presentation today, and thank you for answering all those really important questions.
Thanks for having me.
It's refreshing to have an expert like yourself give this sort of presentation. We've gotten quite a few questions along the way. What I'd like to suggest to everybody is if you have any further questions, reach out to your local APDA Information Referral Center or your local chapter and try and get somebody that might be able to answer your questions. Here in Massachusetts, so can you move the slide forward, please, Dr. Deb? Thank you. Here in Massachusetts, we have an Information Referral Center at Boston University Medical Campus. The phone number is 617-638-8466. We work with local referrals and resources. Across the country, the APDA provides education and support. We've got support groups across the country. We deliver symposiums and educational events, many of which right now are virtual. From a health and wellness standpoint, we've got exercise and movement classes across the country, dance, yoga, tai chi, boxing, and more. Some are being delivered in person and some are virtual. We have a fitness professional trainer program. And here in the Boston area, we have the APDA National Rehabilitation Resource Center that Dr. Deb referred to earlier at Sargent College. It's a 1-800 number. You can find the information on the APDA website. And that's a number that you can call if you have any questions regarding exercise or rehabilitation. I want to thank Dr. Deb for a fantastic presentation today. We're really, enthusiastic about the information that was shared, and we're very happy to have great partners like Dr. Deb here with APDA. We look forward to seeing you down the road. If there's anything that you would suggest or you have feedback about, please let us know. Next slide, please. You can follow APDA here in Massachusetts. We have a Twitter account, which is twitter.com Parkinson's MA, Facebook account, APDA MA, and an Instagram account. You can also see our website, apdama.org. And again, if you have any questions or any suggestions moving forward, just reach back out to us. Want to thank everybody for participating today. This has been recorded, and we hope to have it on our YouTube page within the course of this week. We will send out the link to everybody who has participated and those that have registered for the event. Again, we want to thank Dr. Deb and UMass. Great presentation, and thanks so much. Have a great day, everybody.